So, well, thank you. I will tell you, this is a packed house tonight. I know our national conference was packed, but last time you couldn't see everyone at our national conference. Tonight on the grid view, you can see the hundreds and hundreds of people that are here tonight. We have a great topic tonight to cover by an amazing rheumatologist, Dr. Don Thomas, and we're thrilled about being able to cover this topic for all of you this evening. As Don Thomas speaks tonight, feel free to put your questions in the chat room. I'll be monitoring it and writing some of them down to be able to moderate a question and answer period at the end of the evening. We won't be able to get to every question, but you can surely put them in the chat room and we'll try to get to as many as we can. And then we'll hopefully use some of them for future questions for our newsletter as well. But again, thank you for joining me. For those that don't know me tonight, I'm Stephen Taylor, President and CEO of the Sjogren's Foundation. We really appreciate you joining, but we're thrilled that we're able to bring you another educational opportunity like this into your home, so you don't have to go anywhere and you can stay safe in your very own home. We will be having 2 more topics coming up. One on vaginal dryness in 2 weeks, and then 2 weeks after that, we're going to have a dry mouth and dry eye roundtable with an eye doctor and a dentist who will take just the entire hour taking questions from all of you. So stay tuned for the information about the vaginal dryness topic in 2 weeks. And then 2 weeks after that, we're going to be doing the dry eye, dry mouth roundtable. So hopefully you'll be able to take part in those as well. So again, we're thrilled to have Dr. Don Thomas here. Some of you have seen Don Thomas talk before. He's actually an absolute pleasure to watch and learn from. He's also a longtime friend of the foundation. He's actually chair-elect of our Sjogren's Foundation Board of Directors. He's in private practice. He's a rheumatologist in Maryland and is passionate about empowering patients. This evening, he's going to talk to us about fatigue, which is one of the most prevalent and debilitating and disabling symptoms of Sjogren's, as many of you know. I know that he'll add to your variety of knowledge about the disease, and hopefully we'll get to as many questions as we can later on as well. So remember to add questions throughout the talk, and we will get to them at the end. So with that, I will turn the topic and the mic over to Dr. Don Thomas.
A nice topic reminds me of a patient I just saw this past week. And her name is Mary. Mary's not a real name, and this is not a real picture, but I want to keep her identity anonymous, of course. But I've known Mary for a long time. We've actually known each other for about 20 years now. When I first met her, she clearly had an overlap of Sjogren's syndrome along with systemic lupus. 50% of Sjogren's patients do have an overlap syndrome like that. She had inflammatory arthritis, severe dry mouth and dry eyes. She was having hair loss, inflammatory rash, and her blood work showed that she had a positive anti-SSA antibody, high anti-double-stranded DNA antibody, and low complement levels. And those are important because those signify active inflammation. I tried her on several different medication combinations, but finally, the combination of hydroxychloroquine plus Benlysta got her into great control. In fact, she had severe fatigue before that, and her fatigue got under very good control with therapy. Well, after a few years, she came to me one day, and she wasn't feeling very good. When I walked into the room, I could clearly tell she wasn't feeling right. And she told me how during the past few months, she was having a lot of problems with ongoing fatigue and tiredness. She was so tired that she had great difficulty doing many of the things that she enjoys doing in her life. She felt like she was being robbed of her life. She also told me that she had trouble with memory. Her concentration was poor. She told me she was in a Sjogren's or a lupus fault. And I know many of you can identify with that. It's a common problem in our patients. And then she told me she had great difficulty sleeping at night. When she would wake up in the morning, she felt unrefreshed, like she didn't have a good night's sleep at all. And she had gained 20 pounds of weight. The fatigue, the difficulty sleeping, and the 20-pound weight gain were her main complaints. So she had some requests for me. She wanted a sleeping pill, she wanted a weight loss pill, and she also wanted some energy vitamins. And I'll just say right now is that most patients ask me for vitamins to help their energy. They don't work. I'll just put that out there right now, unless someone actually has a vitamin deficiency. Vitamins help people with energy about 30% of the time. That's the placebo effect. So with Sjogren syndrome, the first thing to figure out when someone has fatigue is there active inflammation going on in the body from the Sjogren's? And Sjogren's can attack any part of the body. And so as the physician, my job is to see if there's any active inflammation in any of these organs or systemically. So I do a physical exam. I can look at the parotid glands, see if there's any inflammation of the salivary glands. They'll be tender to touch. Sometimes they'll be red. Some patients get sores in the mouth. She did have sores in the mouth when I first saw her. They're more common on the upper palate, but they can occur on the tongue, just like on this gentleman. Absolutely, inflammatory arthritis is common in our patients. The picture that you see here shows a joint. There's two bones coming together, and the space between the bones is the actual joint. And then you see the red tissue that's connecting one bone to the other. That's called the synovial joint capsule. And usually that joint tissue is only one cell thick. But this is incredibly thick because of inflammation. And that's what happens with Sjogren's inflammatory arthritis. And look at the middle joints on the hand there. They're swollen and they're a little red. And if you feel them, they're boggy or rubbery. And this is the type of arthritis that she used to have, but she didn't have that on her examination. And by the way, if everybody looks at their own hand right now and you feel your own joints, some of you are going to feel some bony swelling. Well, the bony swelling is not Sjogren's arthritis. That's osteoarthritis or degenerative arthritis. And all of us after the age of 50 years old get some osteoarthritis somewhere. That doesn't count. That's not part of the Sjogren syndrome. Well, she didn't have active arthritis. She used to have an inflammatory rash. This is a typical rash of Sjogren's. It's exclusively seen in our patients who are anti-SSA positive. I also listen to her lungs and her heart. I can look to see if there's any inflammation. We look for something called a rub to see if there's any evidence of pleurisy or pericarditis. She didn't have that. The laboratory test can be very helpful. The sedimentation rate can be high. The C-reactive protein can be high. Gamma globulins can be high. Anti-double-stranded DNA. She actually had all of these when I first met her, but they're all normal. She was doing great on therapy. Complement levels can be low. Hers used to, but now they're normal. And by the way, I'm giving a lot of information during my talk. And a nice thing about the Sjogren's Foundation, they're actually going to put my entire slide set up on their town hall section of the website. So you'll be able to access all this later. But even more importantly, I'm going to include a really good handout that has some very good practical information on it about things that you can do to help out with your fatigue. So once it's up on the website, I would recommend that you download the handout, actually print it out, and I'd recommend that you sit down at your coffee table, take a yellow highlighter, and then highlight everything that you're not doing and try to work on as much stuff on there as you can to help your own fatigue. We can also look for inflammation in other organs of the body. For example, we can look at the liver function test to see if there's inflammation of the liver. The muscle enzymes can show us that there's inflammation of the muscles. Protein in the urine can be indicative of kidney inflammation, anemia of inflammation on the complete blood cell count. And we can look for low white blood cells and low platelet counts. She had none of that. A couple of other things that can happen in Sjogren's patients that can cause fatigue is one thing is interstitial lung disease. It occurs in about 15% of our patients where they'll get inflammation and scarring of the lungs, and they certainly can have fatigue with it. And primary biliary cholangitis, used to be known as primary biliary cirrhosis, this can also occur and it can also cause fatigue, but she didn't have either one of those. Well, if I do identify someone who has Sjogren's inflammation that's active, I absolutely want to treat it. The drug of choice is hydroxychloroquine, or also known as Plaquenil. I know everybody's heard of this recently because of COVID-19. But studies show that it can help patients with Sjogren's fatigue. And very interestingly, the Sjogren Syndrome Foundation just did a really nice survey on Plaquenil. And what it showed is that over 70% of the respondents who had taken Plaquenil said that it helped their fatigue. So we're pretty sure that it does help a lot of patients with their fatigue. If you have Sjogren's and if you've never been on Plaquenil, it's by far the safest medicine we have. So I'd recommend you go back to your rheumatologist and say, is Plaquenil a possible therapy for me to see if it would help with my fatigue? If you do go on it, you have to give it at least a full year to get the full effect. and make sure that you get yearly eye examinations as well. Rituximab is a medication that decreases the amount of B cells. B cells are a type of white blood cell, and in Sjogren syndrome, the B cells are overactive and there's too many of them, and that's what's actually attacking the salivary glands and the tear glands and so forth. And Rituximab, or Rituxan is the trade name, calms that down. It's FDA approved to treat rheumatoid arthritis. And so if you have rheumatoid overlap with your Sjogren's, it's usually pretty easy to prescribe to patients. As I mentioned, my patient is on Benlysta along with her hydroxychloroquine. Nice thing about Benlysta is that it seems to do very well with the fatigue that can occur. It especially works well in patients who have a high anti-double-stranded DNA level and low complement levels, just like my patient. But those were perfectly normal since she's been on therapy. So I knew none of these were for her. But if you have lupus overlap with Sjogren's, you may want to ask your doctor about Benlysta. A very important thing when you have Sjogren's and fatigue is make sure that you treat the dryness. One of the biggest problems is that dryness oftentimes will wake people up in the middle of the night. Dry, itchy skin, their mouth will be dry, the eyes will be dry, and this can be very bothersome. You absolutely must have a humidifier in your bedroom to help out. In addition, you want to learn everything you can about moisturizing the eyes, the nose, the mouth, and also the skin. Go to sjogrens.org and make sure you join the Sjogren's Foundation if you're not a member. You can actually download very helpful pamphlets that can go over how to care for the dryness. Another problem with Sjogren's, and this is something that many physicians may not think about looking for, is something called dysautonomia or autonomic dysfunction. Many patients with Sjogren's, the Sjogren syndrome will attack the nerves of the body, and there's a lot of different nerves. And what I'm talking about here is something called the autonomic nervous system, and it means exactly what it sounds like. Autonomic, referring to that as automatic. And what that means is very different from the part of the nervous system where I can make myself do things. For example, if I want to make a muscle, I'm doing that voluntarily. That's not the autonomic nervous system. However, if I go out there and run, I need oxygen to get to the rest of my body, so my heart beats faster. It beats faster because there's an electrical system that makes it beat faster, and that's the autonomic nervous system. If the Sjogren syndrome attacks it, then we call it dysautonomia. This means abnormal, so abnormality of the autonomic nervous system. Autonomic dysfunction is another name. One of the types of dysautonomia that can occur is POTS. POTS stands for Postural, Orthostatic, Tachycardia Syndrome. That's an awful big mouthful to say, and you can understand why we say POTS instead. What those words mean are, postural means that the symptoms come on with different postures. Orthostatic refers specifically to when the person stands up. Tachycardia means fast heart rate. Tachy means fast, cardia refers to the heart, and then syndrome means that this is a collection of symptoms and signs. So what happens that when the person and the way that this happens, I'll explain, is when we normally stand up, we don't notice anything at all. We stand up, do our own business, and that's how it should be. The reason for that is that when we stand up, the blood wants to go down, the gravity pulls blood down to the legs, and if it were to do that, our brain wouldn't get enough blood. So what happens is that as soon as we stand up, the autonomic nervous system squeezes on the arteries in the legs to push the blood up to the major organs, to include the brain, so that we don't have a problem. The problem with POTS is that that doesn't happen. And so when the person stands up with POTS, those arteries don't constrict like they should. The heart starts to beat a lot faster to get blood up to the brain, and then that's the tachycardia part. And so there's definitely that abnormality. They can get dizzy, they can get lightheaded. Fatigue is an absolute part of POTS syndrome, but also they get the heart palpitations and many other symptoms as well. You can actually do a test at home, by the way, to see if you might have POTS. If you have a problem with dizziness or lightheadedness, you can actually do this at home, but please let someone else do it along with you. Don't do it by yourself like the lady is doing in the picture right here. What you want to do is lay down for 10 minutes. Don't talk, don't converse or anything, but just you be totally relaxed. And then you want to have your partner who's helping you out check your heart rate and your blood pressure. So make sure you use a blood pressure monitor. Then you want to stand up. And make sure that your helper is making sure that you don't fall down or hurt yourself if you get dizzy or lightheaded. And then every few minutes, check the blood pressure and the heart rate, especially at the 10-minute mark. If your heart rate goes higher, or 30 beats per minute or higher than your laying down heart rate, then that's an abnormality. And with POTS, the blood pressure stays about the same. The blood pressure should not drop. And so if your heart rate goes up, but your blood pressure stays the same, you might have POTS, and bring it up to your doctor to see a specialist for POTS. By the way, if your blood pressure drops, then that's a different problem. It is an autonomic problem, possibly called orthostatic hypotension. And medications are a very common cause of that, but please see your doctor if you notice that happens. But you can do this at home. As far as the treatment for POTS, there's absolutely treatments available. In my area of Washington, D.C., I have a fantastic doctor that I send all my patients to, and he does a great job. Exercise is an absolute must. That's why it's in big letters here. But also drinking lots of fluids to stay hydrated and avoiding inactivity. The reason exercise is in capital letters is because every study looking at exercise shows significant benefits in POTS. For example, one study that was done in 2005, they took people that would get this lightheadedness and dizziness when they'd stand up. Half of them, they let them do whatever they want. The other half, they made them jog. So just think about that. You have POTS, the last thing you want to do is jog, but they made them jog for exercise. At the end of 3 months, guess what happened? 90% of the joggers had marked improvements in their symptoms. And the other group that didn't do anything special, 30% got better. And that's the placebo response. We expect to get about 30% response rate in almost any study that we did. So exercise does help, but just be careful. I wouldn't have my patients jog. I would have them start off with like a recumbent stationary bicycle or another type of bike, and then maybe build up to an elliptical machine or a treadmill. And by the way, if you think that you can't exercise, every single person with Sjogren's can exercise. Someone who's paralyzed in their legs can even exercise. If you don't think you can exercise or unsure how, what I do is I like to send my patients to a physical therapist. The physical therapist can measure your actual physical health and your biometrics and your exercise ability and design a safe exercise regimen for you. Medications can also help POTS. They use medicines that can help increase the blood pressure, and that can help increase the fluids in the body as well. So many patients have a lot of difficulty exercising when they have fatigue. And my patient, Mary, she told me that. She said, you know, even though I was so tired, I just forced myself to exercise. And whenever she falls off the wagon, she tells me, I know what to do. I hate to do it, but I'll start exercising again. Every study that's looked at exercise for the treatment of fatigue has shown benefits for systemic lupus as well as for Sjogren's syndrome. We know it absolutely works. I work over 60 hours a week, but I do my exercise. I exercise 150 minutes a week, like the Centers for Disease Control recommends. I come home and I'm tired. Oftentimes I'll lay on my couch. I'll watch my favorite reality TV show. Nowadays it's 90 Day Fiance. And I'll tell myself I deserve it to be just relaxed and just be able to just relax and take it easy. But then I tell myself a mantra. I tell myself that exercise is as important to living as eating and sleeping. And I'd like you to think about that. Eating is important, none of us would go without it. Sleeping is important, none of us would go without it. The same goes for exercise. At this point, I have a lot of patients in my clinic who are in their 60s, 70s, 80s, and even 90s. When I look at my exercisers versus my non-exercisers, there's a huge difference. My exercisers with Sjogren's and lupus and rheumatoid, those are the patients who are going on vacations, they're having a great quality of life, and it's just amazing to see how well they do. The non-exercisers, unfortunately, it's a downhill spiral with time, and I hope you don't let that happen to yourself. Now, I know that a lot of you who are on the call or on the Zoom meeting right now exercise regularly. And I would love it if you go down to the chat box, see where it says participation on the bottom of your screen, and then you'll see the chat next to it. Just click on that and then type in how you like to motivate yourself to exercise so that you can give some good tips or hints for other people who are not used to it. Or if you used to think that you couldn't exercise, what was your trick to help you learn how to exercise? We would love to know and share that information. Now, treating dysautonomia is a very difficult thing. Very few doctors are actually experts at doing this. I'm very fortunate to have my favorite doctor in the area. But if you're not sure who to contact and if you have dysautonomia, go to the Dysautonomia International Society, and I put the website right there, which is dysautonomiainternational.org. And they actually have a list of doctors who specialize it throughout the world. And you can contact them to help you out. So she had none of that going on. Her Sjogren's was under great control, by the way. So next we can look for blood counts, see if the patient's anemic, like iron deficiency anemia, very easy to treat. An overactive thyroid or underactive thyroid can cause fatigue, also easy to treat. Vitamin B12 deficiency, as well as vitamin D deficiency, can also cause fatigue, very easy to treat again. Celiac disease. Celiac disease occurs more common in Sjogren's patients. Everybody has seen the section in the grocery store that's the gluten-free foods. That's what celiac disease is all about. It's due to gluten hypersensitivity. When people with celiac disease eat gluten, which is in wheat products and other types of grains, it causes an inflammatory autoimmune reaction in the intestines, and they malabsorb their food. And so they end up getting nutrient and mineral deficiencies, and they can get very tired along with this, but it's very easy to treat. For me, it's very easy to treat because I tell them not to eat gluten, but that's a hard thing to do actually. But when they do that, they get much better. It's very easy to diagnose with blood tests, and we can also do an endoscopy where we have a GI doctor look down into the small intestine and take a small biopsy to diagnose it. Hepatitis C absolutely causes fatigue. Most people with hepatitis C infection, which is a viral infection, don't know they have it. Today's medicines can cure over 95% of patients. That's just a miracle. It can prevent cirrhosis and liver cancer that can happen with Hep C. The Centers for Disease Control recommends that all baby boomers, people born in the 1960s and earlier, everyone should have a hepatitis C test. And if you haven't had one, please ask your doctor to do it. Well, all of these was normal on Mary. The next thing I look for are medications. There are many medications that can cause fatigue. And this is just a list of them. And again, you'll be able to access the slides. Typically, though, when someone gets fatigued from a medicine, it happens very soon after going on the medicine. So it's usually pretty easy to pinpoint, but it doesn't always happen that way. For example, let's say you were put on a Atenolol, which is a blood pressure medicine. It's notorious for causing fatigue and tiredness. You might do amazing on it. And then 10 years later, your body starts to metabolize medicines less efficiently. The Atenolol starts to cause some side effects at that time, and then you'll get fatigued and tired. If you're on any medicine that can potentially cause fatigue, you might want to talk to your doctor and say, can we do some experiments, stop any of the medicines, see if my energy level gets better? That's the only way to figure it out, but only do it with a doctor's guidance. Alcohol is in capital or is in large letters because it's a very common cause of fatigue. A lot of people will drink alcohol before bed to thinking that it's going to help them sleep at night, but it does just the opposite. Alcohol does help people fall asleep, but it also interferes with the sleep cycle at night. We all want to go to a deep stage 4 sleep and REM sleep, but alcohol prevents that from happening. And so it actually causes people to be tired because they don't get a full night's sleep. One of the things I'm going to give in my handout is called sleep hygiene. And on that sleep hygiene handout, it says not to drink alcohol several hours before bed. This slide is very important. All those things I just mentioned are really important to make sure the person doesn't have when they have Sjogren's. But the list you see here are by far the 4 most common causes of fatigue in our patients. When someone tells me they're fatigued, the very first thing I ask them is, well, how many hours of sleep are you getting at night? And this is the most common cause of fatigue, by the way, in the entire population, the general population. Mary, she told me 5 hours of sleep. If you don't get at least 8 hours of sleep at night, you have to work on getting 8 hours. She was a principal of a high school. She loved to stay up late at night and watch her favorite show, but she had to get up at 5 o'clock in the morning. That just doesn't work. And so there's a very important handout that you can download that's part of my handout called Sleep Hygiene Techniques. It's a list of do's and don'ts, things that you should do and avoid doing. And I guarantee almost everybody on this Zoom meeting is absolutely not doing everything. We can all improve upon our sleep hygiene. But also sleep apnea, depression, anxiety disorder, fibromyalgia, those are all 4 common causes of fatigue. I won't go into what each of those are, but many patients with Sjogren's have these problems. In the handout that you download, there's actually some self-tests that you can take at home. There's a test that you can take for sleep apnea, one for depression, one for anxiety, one for fibromyalgia. Do the test, and if you score high on the test, take it to your doctor and ask them if you had that disorder, and if so, you want some treatment to get better. So my final diagnosis for Mary is that she absolutely was not getting enough sleep. She had poor sleep hygiene, and she also absolutely had depression. Every symptom she had was actually a diagnostic criteria for depression. We use diagnostic criteria and weight gain, not sleeping at night, increased hunger, the lack of interest in doing things she enjoyed, fatigue, and also memory loss. All of those are things with depression. So I told her that's what she had. My prescription for her is I wanted her to exercise regularly. I wanted her to work very hard at her sleep hygiene. She needed to go on a healthy diet, and I would like her to work on weight loss. I also told her, by the way, that if she'd like, I could give her an antidepressant to help out as well. For example, one called Paxil. But I tell her I prefer most patients to first work on the non-medicine treatments. And the reason for that is that most patients actually do well on them. In fact, they did a study. They put patients on exercise versus Prozac. And the exercisers did just as good as the Prozac, but without the side effects of the Prozac. So I gave her a prescription for Paxil as well. And then I told her I'd see her back in a couple of months. So a couple of months went by. Mary came to see me, and I went into the room. And Mary was not very happy. But I talked to Mary and I asked her how she was doing with the homework assignment I gave her. She wasn't doing the exercise. She didn't work on the sleep hygiene. I asked her if she was doing specific things on it, and she didn't take the Paxil. So again, I educated her about depression, about how it's a chemical imbalance disorder. It's not her fault, and that she can do these things to help herself out. And I told her I'd see her back in 3 weeks because I want her to take the Paxil, and Paxil takes about 3 weeks to work, and I'll know how she's doing. So she came back in 3 weeks, and I went inside the exam room. I said, "Hi, Mary." And she was angry. And I mean, she was angry. Have any of you ever gotten angry at your doctor? Type it in the chat box. And I know you have, because I've had patients get angry with me. Anyway, she told me, "Dr. Thomas, you're not listening to me. I told you that I want to lose 20 pounds of weight. I have no energy at all. I don't have my life, and you're not helping me at all." And so she literally yelled at me during that time period. And so I told her I really want her to do what I asked her to do. She literally stormed out of my office and just left without even making an appointment. Well, at that point, I just felt that we weren't a very good match as far as patient and physician. And this sometimes happens. Not all doctors and patients have a personality that matches up with each other. So I very nicely typed her up a letter, and I told her that, you know, she might want to get a second opinion from another rheumatologist. And I gave her some names and numbers, and I told her I would like her to not come back, but see another rheumatologist instead. So I like to change topics. In England, there's a very interesting clinic called the CRESTA Fatigue Clinic. It's part of the National Health Service, and all this clinic does is they treat fatigue. And they've done a couple of very nice studies specifically in Sjogren's patients. And they had remarkable results. Most of their Sjogren's patients had significant improvements in fatigue. And guess how they treated them? They didn't use medicines. They used no medicines. They worked on pain management because many patients have chronic pain with their fatigue, but they didn't give them pain medicines. They taught them how to live with chronic pain. because chronic pain, a lot of it is learning how to deal with the pain and how to learn with the pain. Talk to anyone with chronic pain who's managing it, and they'll be able to tell you that. And it's a learnable thing. Also, they recommended exercise, just like I keep telling you to do. Pilates was another thing they incorporated. The sleep hygiene handout that you can download once they put it up on the website. Energy management, you have to realize that you only have so much energy every day, and you have to learn how to just do little bits at a time and know what your limits are. And then stress reduction. People who don't manage stress very well, they're absolutely more fatigued than that person who's optimistic and everything seems to bounce off of them and they seem to not have very much stress. We can all learn how to reduce stress. Everyone can learn the secrets and some tips on how to improve your response to stress. In fact, it's so important. I put a stress reduction recommendation handout in my handout as well. And if you're a stressful type of person, I'd recommend you read through it. On Facebook, the CRESTA Fatigue Clinic also has a group that you can join. And so if you have significant fatigue, they give lots of helpful hints on a regular basis and tips. Just do a search for CRESTA Fatigue Clinic Health Champions, and you can go ahead and join that group. So again, I want to say exercise is the most important thing. They've actually done a lot of studies now looking at both Sjogren syndrome and systemic lupus. Every single study that looked at fatigue showed significant improvements in those who exercise regularly. You should work on trying to get 150 minutes a week of moderate aerobic exercise, and consider my mantra. Exercise is as important to living as eating and sleeping. And just remember, when Dr. Thomas sits on the couch and is lazy, he says, Don, exercise is as important to living as eating and sleeping. Get your butt off the couch and go on your elliptical machine. I go to my elliptical and I watch my 90-Day Fiance. So what happened to Mary? Well, Mary, she ends up calling my medical assistant about 6 months later after I last saw her, and she pleaded with my medical assistant. She said, please ask Dr. Thomas if I can come back. I promise I'll be a better patient for him. So I'm a reasonable person. So I told my medical assistant, sure, put her back in. So I came into the room, and this is what Mary looked like. She had a huge smile on her face. She looked fantastic. She looked like her old normal self, and she had clearly lost weight as well. She said, Dr. Thomas, that letter that you wrote me was a wake-up call. The entire time, I knew the right things to do, but I just wanted to try to get an easy way out. So after I got that letter, even though I felt so tired, I started to exercise regularly. I joined Weight Watchers and worked on my diet as well. And I took the Paxil. And it's just done miraculous as far as how I feel and my mood, and my family says I get along with them much better. So I've known Mary now for about 20 years, and we get along great. We're almost like friends at this point. Every once in a while, she'll fall off the rocker or fall off the horse, and she'll go into a depressive state. She'll gain 10 pounds of weight. She'll go off of her Paxil, but she'll say to me, she'll say, Dr. Thomas, I know I'm not doing the right things. I've just been under a lot of stress. I'll start doing everything, and then she'll come back and she's doing a lot better again. Now, I'm not saying that you can get rid of fatigue in every single patient. And so I'm not saying that what I did for Mary will work in everyone. But what I am saying is that I guarantee that if you have significant fatigue, if you download my handout, and if you sit down and you really highlight those things you're not doing and clearly work on trying to incorporate those slowly in your life, I guarantee you'll get better than if you don't do them. And then you can learn to conquer the fatigue of Sjogren's rather than let Sjogren's conquer you. And I'll be glad to answer any questions.
Thank you, Dr. Thomas. We have tons of questions that are flying in the chat room. And I'm going to jump in first with a few comments. One is, I just want to reemphasize Dr. Thomas's, so we can take a break from talking for a minute, his comment about physical therapy and exercising. So some of you have insurance that will cover physical therapy, some of you won't, so you might not be able to do this, but your doctor can refer you to a physical therapist so they can teach you some ways to exercise slowly for your body to work yourself up. Dr. Chad Jor, who spoke at our national conferences before and is on our board, talks often about patients just starting small to exercise. Because some of you are sitting there, and I know I can't see everybody, but I'm sure you're rolling your eyes about exercise. And I hear it from patients who call me who don't want to do our walks because they can't walk or they can't take part in events like that. And that's fine. But when we say exercise, it doesn't mean going out to run a 5K or a 10K or going, to the local track and playing lacrosse with your grandkids. It means starting small. So that means walking to your mailbox and back 3 times a day. Then you get up to 4 times a day and then 5 times a day. If it means just stretching, to do some stretches or yoga, which some of our town hall meetings in the spring talked about. And I encourage you to go on to those town hall meetings that are on our website. We have one on yoga and mindset and meditation. We also have a great town hall meeting. They're free of charge right on our website on exercising. But Mary Wiseman from New Hampshire, her niece has Sjogren's, and she did a great exercise town hall meeting where she showed you various stretches you could do at your home to get your body stronger, and easy things to do that you can do in your own home without having to go to a gym. So I encourage you to go watch those as well, just to get started, and or look at that idea about physical therapist as well. But really you can start without one. And ask your doctor. They might even have handouts in their office they could give you. So I just wanted to mention those town hall meetings to you. In addition, so I'm going to jump right in, Dr. Thomas, with this question. A person wrote that they were recently diagnosed with Sjogren's and lupus. Their doctor prescribed 5 milligrams of prednisone. However, it was caused bloating and weight gain. But when they only take half the pill, they feel very sleepy throughout the day, even though they're not doing anything strenuous. Do you have any suggestions for that?
Absolutely. That's a great question, Steve. So one thing I'll say is that any of you who's been on prednisone can probably identify with the weight gain thing. When someone gains weight on prednisone, they automatically have something called a Cushingoid effect to the prednisone, which means that all of us, we all make prednisone on a daily basis. There's 2 little glands that sit on top of, there's one gland that sits on top of each kidney that's very small. It's called the adrenal gland. And the adrenal gland makes about 5 to 7 milligrams of prednisone every day, or equivalent of steroids every day. Steroids are actually essential for us to live. We can't live without steroids. But the problem is that when you're put on prednisone or any type of steroid for any length of time, the higher the dose, the worse, and then the longer you take it, the worse. But the adrenal glands see all that steroids and it says, oh, we don't need to be making steroids anymore. And they actually atrophy. They get smaller than normal and they're not able to make enough steroids anymore. We call this adrenal insufficiency. And when someone gains weight and becomes Cushingoid on steroids like prednisone, that's an absolute 100% sign that they do have adrenal insufficiency. And when you have adrenal insufficiency, you have to come down on steroids incredibly slowly. You have to actually make the adrenal gland exercise and learn how to make steroids again and get larger over time. And so if I have someone who's on 5 milligrams of prednisone with that, I would not go down to 2.5 milligrams. I would go down to 4 milligrams. I would give them 1 milligram tablets and have them take 4 each morning. I would do that probably for a few months before I'd even try to go down again, just 1 milligram at a time. Some patients can't do that. Some patients have to go to 5 milligrams, alternating with 4 milligrams every other day. And sometimes you have to go down just ridiculously slow. So that's a great question. And a lot of people don't realize it. Don't put up with it. Let your doctor know, because we can get around it by just going down slower on the taper of the prednisone.
That's great, Dr. Thomas. Someone asked a question about anemia. Does Sjogren's cause anemia, and what can you do about anemia?
The answer is yes. Sjogren's syndrome very commonly causes anemia. In fact, all of the systemic autoimmune diseases do, and Sjogren's is a type of disease called systemic autoimmune disease, such as same as lupus and rheumatoid arthritis, and all of them can cause anemia. They can cause something specifically called anemia of inflammation. We used to call it anemia of chronic disease. And what this means is that the inflammation that's going in the body from the Sjogren's, it actually interferes with how the bone marrow makes red blood cells. And so the bone marrow stops making very many red blood cells, and the hemoglobin and the hematocrit go down. In most patients, it's not bad enough to cause fatigue, but occasionally it can. And in those patients, we can actually give them medications such as Procrit and make the red blood cell count come up. And these patients, by the way, they have normal iron stores. They have more than enough iron in the body. So please don't take iron if you're told that you have anemia of chronic disease, unless your doctor did a blood test and found that you're also deficient in iron, because there's already enough iron there. You just have to calm down the inflammation. When we treat the inflammation, or if we give a medicine like Procrit, then it improves.
I have another question regarding peripheral neuropathy, and kind of explaining, is there a connection between peripheral neuropathy and having fatigue? And also this person added another question is that they tried gabapentin, but it didn't work necessarily, but would love your take on treating neuropathy.
Certainly. So as far as peripheral neuropathy and what that means for people who know, with the nervous system, we have a central nervous system, which is the brain and the spinal cord. And then there's the peripheral nervous system, where the nerves come out from the spinal cord and go into the arms and the legs and the trunk of our body. That's the peripheral nervous system. Very common, by the way, for Sjogren's to attack it. One of the most common things that we see in Sjogren's syndrome. The typical symptoms are tingling or numbness. It starts in the feet, by the way. And when it's really severe, it can cause a burning pain. And this burning pain typically happens at nighttime when the person goes to bed. And that's the biggest, easiest clue for me to figure out if someone has peripheral neuropathy, is that nighttime burning pain or tingling or numbness. And then we can use medicines like gabapentin to help out. And I'm not a neurologist, but to my understanding, peripheral neuropathy probably does not cause, well, no, let me take that back. Peripheral neuropathy, like the one I'm talking about, I don't think it causes fatigue, but autonomic neuropathy does cause fatigue, just like I talked about. And the reason I kind of took my words back is that the autonomic nervous system is actually part of the peripheral nervous system. But when we talk about peripheral neuropathy, we usually are not talking about the autonomic nervous system. So to my knowledge, I don't think that the usual type of peripheral neuropathy does, but autonomic dysfunction does. As far as the gabapentin, the thing with nerve pain or we call it neuropathic pain, is that there's a lot of different medicines we can use. But the downside is that every single medicine either may not work, or they can cause side effects like dizziness, drowsiness, weight gain, which people don't like the weight gain, of course, blurred vision, and many other possible side effects. And so I always tell patients, you have to weigh the risk and the balances of how much the neuropathy bothers you, and whether you're willing to consider the possibility of side effects. And if it's interrupting your quality of life, if you're not getting a good night's sleep, then it's time to take a medication like gabapentin. So if gabapentin doesn't work, then there's other classes of medicines we can use. I wouldn't try Lyrica, because Lyrica is related to gabapentin and it's as likely to cause the same side effects. So I would try something from a different class. For example, duloxetine or Cymbalta, you might have seen the commercials on TV a few years ago that it was for diabetic neuropathy, but we also use it for chronic pain of all types and diabetic neuropathy and Sjogren's neuropathy as well. Another group of medicines we use are what's called the tricyclic antidepressants. These are medicines like Elavil, amitriptyline, nortriptyline. They're antidepressants, but we use them very differently in Sjogren's. You just use little tiny doses. Just take one dose 2 hours before bed at night to help out, and not the high doses that we use for depression. There's lots of other medicines as well, and basically it's a trial and error of trying to find the best medicine for the right person without causing side effects. And by the way, every single one of these medicines are slow to work, unfortunately. They all take 3 to 8 weeks to get the full effect.
Right. And that's the challenge. So you want immediate gratification, but sometimes it takes time to see that gratification. So you have to stick in there, including with a lot of our medications, both even our dry mouth pilocarpine or which is Salogen, or cyclosporine, which is Evazac. Not cyclosporine, but cevimeline, which is Evazac for dry mouth. That takes time to work as well. Real quick question, which someone said, so going out and doing yard work or being busy around the house, cleaning, is that considered exercise, or how would you do that? I do think it's a good question, just so people kind of know, you're not looking for high aerobic exercise, but there is a way to get there. So what would you say about that, Don?
I love this question, Steve. When my patients tell me that, guess what I tell them? I tell them that's being alive, that's living. That's what we should be doing. and people tell me, oh, I go on the metro and I have to walk 3 blocks to work. And I said, that's being alive. That's what you're supposed to be able to do. But the thing is that there's a gradation in exercise. Certainly doing that movement is some sort of exercise, but it's not the type of exercise I'm talking about. You can look at exercise as a continuum from the person who's truly a couch potato, lays on the couch, watches TV all day, gets up to get them a snack, lays back down. There's absolutely people like that. What that person is doing compared to what you're doing with the yard work and everything else, you're doing markedly better, and your health would absolutely be much better than that other person. But if you truly want to exercise, you want to push it up a notch. You want to push yourself to say, okay, I'm going to spend 10 minutes now by doing a brisk walk. I'm going to get myself out of breath during that walk. And then I'm going to try to build it up over time until I get to 30 minutes. And that's what I really like to hear from my patients about exercise. I want them to be alive and doing things and doing activities, because that's being alive, but you can add additional extra steps with exercise as well.
That's right. Okay, great. Thank you, Don. Another question is there a correlation between food absorption and fatigue, both the process itself and any subsequent malabsorption of nutrients?
Okay, so this is a good question as well, and certainly if your vitamin levels are low, you can certainly have fatigue and tiredness. So someone who has had gastric bypass surgery, for example, and if they end up getting a low vitamin B12 level, low vitamin D, absolutely occurs in patients who aren't good with their vitamins after gastric bypass. Absolutely, they can get fatigue. And as I mentioned earlier, patients with celiac disease and Sjogren's, again, it happens more commonly in our Sjogren's patients, can get fatigue treated by a gluten-free diet. However, and I think that all of us can identify with this, by the way, I try to eat healthy regularly myself. I do something called intermittent fasting, and as soon as I start to eat every day, I try to eat something healthy to try to limit the unhealthy stuff that I do like to eat, by the way. But have you ever gotten into those stages where you've eaten a lot of sweets? I'm a sweet tooth. I love desserts and sweets, and you go from a healthy eating habit to a sweet eating habit, and then you feel horrible and draggy, and you don't have any energy. That absolutely does happen. And by the way, this is one of the questions that was given to us previously, so I didn't know this, but I looked it up in the medical literature. And in 2019, there was actually a group that did a study to look at this, and they called it, the title of their research paper was Sugar Rush or Sugar Crash. And the reason they did that is that there's been some literature that has shown that having sugar and high carbohydrates might actually improve mood, while other doctors think it gets worse. And what they showed is that when they had people eat a lot of sugar at once, that they would get an insulin spike. And then for the first 30 minutes to 60 minutes afterwards, they would have significant fatigue. And so definitely diet does play a role in several different ways.
Absolutely. Thank you, Don. So real quick, I have a few maybe quick questions, I hope. One is low-dose naproxen. I know we get a lot of questions on this. Do you want to explain what that is? I know there's not huge science behind it, but some theories behind it. Do you want to share a little bit about that?
Yes. Today, I rarely use naproxen or similar medicines. Naproxen is in a group of medicines called non-steroidal anti-inflammatory drugs. We call them NSAIDs for short because that's a long name. They're non-steroidal because they're not steroids like prednisone. They decrease inflammation, but only very mildly. But the problem with these, and by the way, there's a whole bunch of different ones. There's naproxen, Advil, Aleve, Motrin, ibuprofen. I could go on and on. The problem with these is they absolutely have a lot of side effects. Prednisone is the worst, by the way. Prednisone, we say that the P in prednisone stands for poison. We want to try to get people off prednisone and get them on something else that can take its place. But non-steroidals are just right after them. The problem with non-steroidals like naproxen is that they increase the risk of heart attacks and strokes. And the problem with Sjogren's syndrome is that the systemic inflammation increases heart attacks and strokes in our patients. That's the last thing I want. Now, if a patient comes to me and they've tried Advil and Aleve and they just have a marked improvement in their inflammatory arthritis, I'll put them on it, but I'll just counsel them about the potential for side effects. If their blood pressure is high, though, I absolutely don't get it. I had them monitor their blood pressure. If that top number goes above 130, they should not be on it. If that bottom number is above 80, they should not be on it. Other potential side effects are ulcers in the stomach, and decreased kidney function, congestive heart failure. I could go on and on, Steve, but I try to avoid NSAIDs as much as possible. But if you do go on one, by the way, naproxen is the recommended one. The reason for that is that all the other ones have been shown to increase heart attacks and strokes, but naproxen has been shown in every single study that it doesn't increase it very much.
What about DHEA? Have you heard of that? And do you ever see anyone on that?
Sure, and DHEA is a hormone. It's actually a male hormone, by the way. It's related to testosterone, and all of us have DHEA. The reason that we started to look at DHEA is that in patients with systemic lupus and related autoimmune diseases, a lot of patients have lower than normal DHEA levels. So they did studies giving patients DHEA to see if it would help out with their disease activity and energy. First of all, the studies for Sjogren's show that it doesn't work. It doesn't help. In fact, the Sjogren Syndrome Foundation a few years ago published a paper on how to treat Sjogren's syndrome. They got international experts together. They scoured the world's literature, and DHEA did so horribly that they specifically stated in there that they recommended not taking DHEA. DHEA may help some systemic lupus patients. In some patients, it might help decrease lupus disease activity a little bit maybe, and it may help decrease prednisone dose requirements and help with bone density, but that's very iffy, but it might help some lupus patients, but not Sjogren's.
And then also, what about naltrexone? What do you know about that and the treatment using naltrexone in Sjogren's?
Sure. And so one thing I'll say is that I'm not an expert in everything, Steve, and this is one of those areas. Naltrexone, I know, is used by some experts to treat fibromyalgia, but how it does for fatigue and fibromyalgia pain, I really don't know. It's not a standard therapy, and I know that they've done some studies that there have been some controversial studies. Some studies show that it's effective. Some studies suggest that it's not effective. We do need more research, but I do know that some fibromyalgia experts do use it in their patients, but I just don't know enough about it to make a good comment on the medication.
That's great. Also, regarding a bad flare, should they push through a bad flare with exercise or listen to their body, and what should they do?
And that's a great question also. So when you have a flare, the first thing you have to figure out is what type of flare it is. And the best way to figure that out is by seeing your rheumatologist, and then they can do the physical exam and all that blood work that I told you about before. And they can figure out, is this really a Sjogren's syndrome systemic inflammatory flare? And also you can tell sometimes yourself, for example, if you have the inflammatory arthritis and these joints swell when you flare up, or if you get the mouth sores or your parotid glands swell up, or you get the rash, then you know you're in a flare. And what I do recommend just taking it easy, relaxing. You do want to conserve your energy and rest, but contact your rheumatologist right away. You want that flare treated. That's incredibly important. But sometimes a flare is not a Sjogren's flare. Sometimes a flare could be a fibromyalgia flare or a depression flare, or you might not be using your sleep apnea CPAP every night like you should. And so you want to find out from your rheumatologist exactly what type of flare it is so you know what the best intervention is.
I had an interesting question. I actually have not heard this answered before, I don't believe. I'm looking for the question so I don't get it wrong. But have you heard of stimulants being used in Sjogren's? So for example, someone went on Ritalin and it really helped their Sjogren's. But do we ever see that in the use in Sjogren's, not diagnosed, like not to be used for ADHD or anything like that, but to use just in Sjogren's treatment? Have you ever seen that? Have you heard anything about it?
I do know that there's no studies to show that it helps out with this. Are we still on, Steve? I saw the Zoom go off.
I don't know where we are. Yeah, we're still on. I don't know what happened.
Yeah, that's right. My screen went off there for a second. Okay, so as far as naltrexone.
And they'll take care of the screen. Got it. Good. We're good.
Okay, and I'm sorry, which medicine did you ask me about again?
Well, Ritalin or a stimulant like Ritalin. Do you ever see that used in Sjogren's?
So there's no studies to show that it helps out with the autoimmune disease or the inflammatory disease of Sjogren's. However, I do have patients who are on it from other doctors to treat problems like insomnia, fatigue, and also fibromyalgia. Again, I don't know enough about it to prescribe it myself, but I do have some patients who are doing well on it, but it's because of those problems and not the inflammatory Sjogren's problem. But I'd like to add something really quick, by the way. There's a lot in the news, of course, and it's very popular now about medical marijuana. Medical marijuana may potentially have health benefits, but I don't recommend it yet because we need more studies and we need to have safer versions, by the way. But it works by actually by attaching to receptors called cannabinoid receptors, and so it definitely has medical effects in the body and physiologic effects. And some of these are actually on the immune system cells, like the white blood cells. And there's some fascinating studies so far that they have actually found some cannabinoid medications that are similar to some of the chemicals that we find in marijuana that actually help autoimmune diseases. So it's very exciting that we might actually someday find some type of cannabinoid related to marijuana that might help Sjogren's. Those types of studies are being done now.
And one question, and then I'll wrap up with a few comments as well, but I'm looking for this question I took pictures of all the screens. I got all your questions on my phone. But someone asked why fatigue is sometimes more worse during a flare. Is there any science behind that or anything?
We don't really know exactly why, but the way that I like to think about it is just think about it when you get the cold or the flu. And I know there's a lot of family members or husbands and wives that are watching right now. Especially think about it yourself, because it's hard to figure out your loved one, what they're going through when they're fatigued. Think about when you get a cold and like all your energy is completely gone. But the difference is that we don't have Sjogren's, we know it's going to go away in 10 days. And then it's amazing. It's like, oh my God, I have my energy back. And with a cold or the flu, a lot of stuff is going on with the immune system. For example, there's a lot of interferon being produced in the immune system. And that goes on with Sjogren's syndrome, lupus, and these other autoimmune diseases. So it absolutely has to do with the systemic inflammation and what the immune system is doing. And it's probably related to what we see with other disorders like infections. But they don't know exactly why, but it does look like interferon is one of the things that is related, and it absolutely does happen. But anyone who wants to think about it, think about when you get a cold or influenza, very similar.
Thank you, Don. I'm going to run through a few questions that were asked real quick myself. One thing I want to remind everybody that we couldn't get to all the questions. Obviously, we will try to use some of them for future newsletters. We can't answer all the questions, but I will say a number of the questions I saw that come through are available in our archived issues of Conquering Sjogren's, which is our patient newsletter. So I encourage you to go onto our website, make sure you're logged in as a member, and you can search in the search tab, and any article or anything on our website, but anything archived in our newsletters will pop up as in the search. So if you want to look up one of the topics that wasn't able to be asked tonight, you can find our old issues of our Moisture Seekers, which was our old newsletter, or our new newsletter, Conquering Sjogren's. We have 10 years of archived newsletters on our website, and you can search anything and it will pop up with those articles. So I definitely encourage you to do that. Regarding, someone asked about dry eye and dry mouth real quick and that keeping them up at night. I'm going to just jump in here. I'm surely not a medical professional, but a few things that I know I've heard many times by other patients is using gels on your eyes before you go to sleep or wearing goggles to sleep at night do help people. And also making sure you don't drink water throughout the night so you don't have to get up to go to the bathroom. So one suggestion I heard many years ago was using a spray bottle of just water next to your bed that you can spray in your mouth when your mouth gets really dry, or you could use one of the spray oral products that are on the market and just spray before you go to bed if you wake up in the middle of the night so you're not drinking water and then having that vicious cycle of always having to go to the bathroom all night. So a spray bottle of just water even helps next to your bed. So I throw that out. And then the last question, which we know we get a lot of questions on finding rheumatologists or finding doctors. It does take trial and error. It is a challenge. I encourage a couple of things. One is you could always go on our website and see which doctors are writing articles for us, which ones have written or answered questions. Our medical and scientific advisors are listed on our site as well. Assume that they know Sjogren's. and you can surely look at them. We don't recommend any physicians because we used to do that many, many years ago, 15 plus years ago, and it became an issue where Mary would call and tell us Dr. Smith was great, and then Joan would call us and tell us Dr. Smith was horrible. Then Karen would call us and tell us again how great Dr. Smith was, and Clive would call and tell us how horrible he or she was. And it became this on-off list thing, and it just is no way, because sometimes it comes down to personality and getting along with them. So I encourage you to look online who's speaking for us. Secondly, attend your local support group. They're going to be going live on Zoom, some of our support groups this fall, and ask them and talk to other patients in your area of who they go, or call our office. And don't all call tomorrow, spread it out, because we had over almost 500 people on tonight. You can call our office and we can give you the phone number for either a local support group or a phone volunteer. We have hundreds of phone volunteers around the country who would love to take questions from patients. They can tell you doctors they've tried or heard about, et cetera, in your area. So you can call and say, I'm from Albany, New York, and we will give you a person in Albany that will give you doctors and talk to you about the disease, et cetera. And so you can do that. And just about, we have volunteers around the country. If you're interested in being one of those volunteers, we definitely need more phone support volunteers. You don't have to run a support group. We don't necessarily need more support groups per se, but we do need some more phone volunteers. So if you're interested, you can look online for the phone support volunteer information, or call the office and talk to Kathy Ivory, and she would love to get more people involved in our phone support volunteer program. And that means you would be willing to let us give your number out to people from your area when they call our office. And then finally, I just want to mention, and Don, I have one final question for you actually in a second. I just want to remind everyone to take care of yourselves, and it's okay. You know, I talk a lot to Sjogren's patients. I've been around as CEO for 17 years. Yes, a lot of you are women, so I'm going to say this, but and there are men on this call that have Sjogren's as well. But typically women are caretakers of their family. And I just said this last night to a group. Typically women are caretakers of their family. They take care of everyone that besides themselves. And that's why I worked for the Heart Association for 9 years. Heart disease is a silent killer of women because women don't know their own cholesterol or their own hypertension, but they can tell you their husband's, or they can tell you their parents' cholesterol or their parents' hypertension number, but they don't know their own. The same in Sjogren's, you have to take care of yourself. And sometimes that means scheduling time to go for a walk or get some exercise and not feeling guilty about it. You should be proud that you get out of bed every day, proud that you battle this disease. Some days are horrible, some days are good, some days, some of you have no days that are really good. And we understand that, but be proud of what you are able to do. If that's get out of bed and get your kids on the school bus, non-COVID years. If you get out of bed now and homeschool your kids like most of us are doing, or you get out of bed and go to work, or you get out of bed and make your husband dinner, or you get out of bed and help your wife do something because you're a man with Sjogren's, whatever it is, you should be proud of that and never be embarrassed that you're battling a chronic illness. Cancer patients that survive cancer are very proud of their survivorship, and you equally should all be proud of your survivorship with this disease that there's no cure for. You're going to live with for the rest of your lives, unfortunately, till we get some better products on the market, which are coming, but you probably still will have Sjogren's. It is important to recognize yourself and be proud of what you're doing as well, and then take time for yourself and celebrate yourself a little bit as well. I do want to end with a quick question to Don. I'm thinking they can be quick answers. Don will, I think Ben will unmute Don. But a quick question on 3 vaccines. So we know COVID vaccine, we don't know any details on that yet. We will be a little concerned about recommending any COVID vaccine since it's being rushed out and we're not sure how that will work. So we will be looking at that come 2021 and figuring out down the road what we think about that. But regarding flu vaccines and shingles vaccines, do you suggest patients get those?
Absolutely. Influenza, 30,000 people to 50,000 Americans die every single year, and people don't realize that because of complications from the flu shot. That's why you see doctors rarely not get their flu shot. When it comes out, I get mine, and I've already had mine this year because we see the horrible things that can happen. You can't even compare how bad the flu is to how bad any potential side effects from the flu vaccine. The shingle shot, the same thing. As soon as it came out, it's indicated for people 50 years of age or older. The Shingrix shot is just amazing. It's 95% effective. It's the best vaccine that we have. You get one shot now and you get another booster shot 2 to 6 months later. But shingles is so horrible. Right now, Steve, during COVID, I've seen a lot of horrible shingles, and I think it's because of all the stress with COVID. One of my favorite patients with rheumatoid arthritis, she came in a few weeks ago, her entire arm was paralyzed. It was paralyzed because of shingles that attack the nerves that go to the muscles. She can't even use it, and I don't even know if she'll ever get it back. And she did not have her Shingrix shot. I had another patient a couple of years ago die from shingles. It attacked her brain. So please get the shingle shot if you're 50 years of age or older. And also you should get your pneumonia shots. There's 2 different pneumonia shots, Prevnar and Pneumovax. Everyone should get those if they're on an immunosuppressant or if they're 65 years of age or older. And then Steve, before we get off, if you could also remind everyone how they can go to the town hall section and download my my handout and when they're able to get that. There was a lot of questions on that.
Yeah. So we'll have that available. We'll be sending out an email to everyone that RSVP'd and was here tonight with links to where it will be, but it will be on our town hall, I think on our town hall tab, which is under, I was just there a minute ago. It'll be on our page, but you'll all get an email from us where it is. It might be on the member side or it might be on the public side. The town hall meetings from back in the spring are under the Living with Sjogren's tab on our site. There's a town hall. You click Living with Sjogren's and then you'll see town halls are listed. You can click there to find all of our spring town halls, which are more on topics of taking care of yourself and well-being during COVID, etc. The fatigue one we'll send out where it will be, but we'll be sending out a link tomorrow to everyone that was on the call with the recording as well as the PowerPoint as well from tonight. So watch for that email, and if you have any questions, you can call the office. I have to ask Carter Wells if you're still on. I do appreciate this caveat. I just said that you call the support group leaders and the phone volunteers, and they could give you some ideas from doctors. I will tell you, not all of them have found great doctors. It does still take time, so they might have ideas, they might not. They might tell you, better yet, they can tell you which ones were horrible, possibly more than they can tell which ones they found. And, each doctor has its own specialty, and I surely say horrible, but, some have focused their careers on other diseases in the rheumatology space, and they haven't really paid attention to Sjogren's as much as we would love them to. So sometimes it takes time to find that. Also, in addition, I encourage you because of COVID, doctors are learning how to do telemedicine. And so I encourage you to look into that as well. If you're in an area that you don't think you have a great rheumatologist or you can't get to a major city, you could do a telemedicine visit at least once a year with a Sjogren's clinic or a Sjogren's expert. Those are opportunities as well. Might be out of pocket, but there is those options as well. So keep that in mind when you hear about other doctors that might not be close enough to you, but might be able to be of help to consult with you once a year. With that, I want to thank also all of you, not only to support the foundation by taking part in these things, but your membership and your donations throughout the year. Obviously, COVID this year has been an interesting year for us. The foundation is doing quite strong, but we do appreciate each and every donation and ensure that we can continue what we're doing to investigate new drugs for this disease, as well as our guidelines, which will be out with pulmonary guidelines later this fall. They're currently under review to be published. And then we'll be bringing them to all of you, which will have guidelines for how to take care of your pulmonary complications, and many other things that we're working on at the foundation as well. So we really appreciate each and every one of your donations, $5, $10, or $50,000, whatever you have given and can give over the years. We really appreciate every single donation. And with that, we're always here for you. That's why we were founded by a patient for patients. And we hope that you'll look to us for advice and ideas or anything you might need. And thank you for taking part. And again, let's give a round of applause for Dr. Don Thomas. Thank you very much. Thank you, Don. We appreciate it. And with that, everyone have a great evening, and we'll see you in 2 weeks. We have the vaginal dryness town hall, and 2 weeks after that, our dry eye and dry mouth call. Take care, guys. Bye-bye. Bye.